It's my pleasure to introduce Twan Lammers. Daryl Alwine should have been talking, but he's not available, so Twan promised to give a talk, and he will talk about monocytes for improved drug delivery and how we can avoid, or how, if we need them, if we don't need them, and how we can get better drug delivery devices.
Thank you, Volker. Yeah, so what I would like to discuss with you is how we can prime the microenvironment, right? How we can actually target the infiltration of certain types of macrophages to change the tumor vasculature and the microenvironment for better drug delivery to tumors. And I think that also has significant impact on eventual immunotherapy, because also PD-1 or PD-L1 blocking antibodies and T cells, they all need to accumulate in tumors. They need to find the right microenvironment there. They need to penetrate, and they really rely on this complex network within the microenvironment of different immune cells to eventually work. So I think within the broader setting in this audience, I do not have to explain this general slide on nanomedicine. What is important here is that a lot of the traditional formulations that we use for classical drug targeting to tumors rely on the enhanced permeability and retention effect, and that this effect is highly variable. And this is something we've been realizing in the last 5 to 10 years. And we actually really need tools to get a grip on this variability. And just to exemplify the variability, I have a patient here, with a Kaposi sarcoma, 3 similarly sized metastases in this upper shoulder region here, and you see a completely different accumulation pattern of nano-based drug delivery systems in these lesions. And I think it's really crucial if we want to move nanomedicine forward in the clinic that we find tools to actually overcome this heterogeneity, this difference in accumulation in different lesions. So I think one of the key things there would be imaging, right? We discussed that also in the plenary discussion yesterday. I think imaging can be of tremendous help to find those patients that are likely to respond, and vice versa, to exclude those proportions of patients that are unlikely to respond simply because the drug or the drug delivery system doesn't get there. And since in the case of passively targeted nanoformulations, there are no real target to stain for if they're not actively targeted, I think we have to rely on such setups to really find a way how we can narrow down the eventual population of patients that we're going to treat. What I'd like to discuss with you today is another aspect of how we can target heterogeneity and the EPR effect, and that's via modulation of the vasculature and the microenvironment. And just as some sort of background information, and I guess everybody realizes this themselves, there is a huge variability in the vascular network in different tumors. And this is a systematic comparison that we did in 4 different tumor models, and this is the same in different types of patients. You see here in these high-resolution micro-CT, contrast-enhanced micro-CT images of perfused tumors, that the distribution and also the size and the properties and the branching of blood vessels within tumors are extremely heterogeneous. Right? Some tumors are very well perfused, very well vascularized. A lot of the volume of the tumor is covered with blood vessels. Other tumors have hardly any vascular perfusion. So no drug or no drug delivery system or no T cell will actually be able to reach many parts within this tumor because blood perfusion is not efficient. So one of the things we've been looking at for a couple of years now is how we can modulate tumor blood vessels. And already more than 10 years ago, Rakesh Jain proposed this concept of vascular normalization. I'm not sure if normalization is really the right word, but I think it really comes down to trying to go from an extremely heterogeneous and poorly perfused network, a chaotic vascular network that we typically see in tumors and metastasis, to something that is more normalized. Right? In terms of vascular density, it's often lower than this highly chaotic tumor, but the overall net perfusion of blood vessels and the distribution of blood vessels and the function of blood vessels is substantially improved. And what we've been doing here together with a company in Germany is we've been looking at inhibitors of the CC-motive chemokine ligand 2. It's an RNA aptamer that blocks the interaction between CCL2 and the CCR2 receptor, which is expressed on monocytes. If CCL2 is present in high amounts, for instance, in tumors or inflammatory lesions, monocytes are attracted to the inflamed or to the tumor's lesion, and they promote pathological angiogenesis. And we have good evidence that that is actually the case. So we started off doing work in liver fibrosis, where you see that these are healthy livers here. These are livers in different stages of fibrosis. This is a second fibrosis model. And in red, you see that during disease progression, there's a substantial increase in the amount of macrophages that actually localize in these lesions. And what these macrophages do is they express, for instance, high amounts of VEGF, and VEGF promotes pathological angiogenesis. So it contributes, in the end, to a less functional overall vascular network. And you nicely see that here. So these are the in vivo CT images. These are the ex vivo CT images. This is a healthy mouse. This is a mouse with liver fibrosis 4 weeks after the induction of liver fibrosis. And you see way more small blood vessels here. So this is typical features of pathological angiogenesis. And what we actually showed is that if we then block this interaction between CCL2 and CCR2, we can substantially reduce the infiltration of macrophages. This is the non-treated case, this is the treated case. So macrophage infiltration substantially decreases. Right? We also saw that with FACS analysis, so we can almost halve the number of macrophages that localize to inflamed livers. And as a consequence of that, we can normalize the vasculature back to how it was before. So you see that here nicely, this is a fibrotic liver, and then if we do anti-CCL2 treatment, we basically bring the vascular network back to how it was at the beginning. And then in the setting of drug delivery and also immunotherapy, I think we can apply the same principle. We can block this interaction between CCL2 and CCR2 to eventually normalize the vasculature in tumors, to enhance perfusion, and to thereby enhance also drug delivery, antibody delivery, T-cell accumulation in tumors. So study setup, very briefly, we used a whole bunch of readouts, but the setup is that we actually took mice with orthotopic 41 tumors, syngeneic model, then we applied for 3 weeks, multiple times subcutaneous anti-CCL2 RNA aptamers, and then we looked at multiple different drugs and drug delivery systems, actually fluorophores as model drugs. So just standard fluorophores as a model for standard chemotherapeutic agents, and then 10 nanometer HPMA copolymers, 100 nanometer pegylated liposomes. And then evaluated with different types of optical imaging up to the microscopy level how the distribution, penetration of drugs and drug delivery systems is improved if we prime the microenvironment. So if we do anti-CCL2 treatment, first thing you obviously see is that the number of M2-like macrophages in tumors is reduced, right? So we do extensive FACS analysis, and then in the MHC2 low tumor-associated macrophage fraction, you see a significant dose-dependent drop of the amount of macrophages that end up in tumors. Also shown here with fluorescence microscopy, so you have MRC1, which is the typical M2 macrophage marker that is significantly lower in tumors if we do anti-CCL2 treatment. And this results in a, if you like, normalized tumor vascular network. So we see overall less blood vessels. Blood vessels are color-coded here in blue with the CD31 staining. We see that those blood vessels have higher amounts of pericyte, so the smooth muscle actin co-staining of CD31 structures is significantly enhanced. That means that these blood vessels are more normal, better differentiated. And as a consequence of that, we also get improved vessel functionality. And for that purpose, we use lectin. So we inject a rhodamin-labeled lectin that only stains perfused blood vessels. And what you see there is that actually going from 30 to 40% of perfused blood vessels in a control 41 tumor, we can go to approximately 70% of perfused blood vessels in a primed tumor. So this really enhances perfusion of tumors. This is also shown here. So if these images would be revolving, you would see that this vascular network in this normalized tumor, it looks much more normal. So the vessels are more properly distributed. They don't have huge lagoons on one side of the tumor like here or here, but it's a more functional, better distributed vascular network. And as a result of this improved network, we also get improved delivery. And this is for a model drug, a 1 nanometer fluorophore. It's just size 7, intravenously injected. And if we then follow with CT-FMT imaging over time how much accumulates in tumors, what you see in the images is essentially nothing, right? Because it's rapidly excreted via the kidney and the bladder. You see that in these images here. But we can actually quantify how much of the model drug accumulates in tumors. And both the peak concentrations and the areas under the curve up to 72 hours after injection, they are increased by a 3 to 4-fold. And we see the same pattern also for drug delivery systems. This is a prototypic polymeric drug carrier, HPMA 10 to 20 nanometers. And also there you see that if we monitor over time in control situations versus in anti-CCL2 pre-treated animals, how much accumulates in the tumors, the amounts in tumors are substantially increased. Right? We don't see this here at the early time points because these systems rely on the EPR effect, so they need time to accumulate within tumors. But then at 24 and at 72 hours, we have a 2 to 3-fold enhanced concentration or higher concentration in the tumor and a higher AUC. And this is just verified here with ex vivo organ analyses. These are all the organs harvested from the animals, put side by side. And it's actually really striking to see that we see the highest amounts in tumors, even higher than liver. But please take into account that this is fluorescence reflectance optical imaging. So these images are, in a way, false positive for tumor accumulation because the liver absorbs a lot of light. So the total amount is not reflected by the amount of fluorescence you see in the liver. Right? So we know that the amounts in the liver are if we quantify accurately, they're in the same order than tumors. Anyway, the main message here is that in tumors, if we prime, the concentration is much higher than in tumors if we do not prime. And we confirm that with different types of microscopy. Here with fluorescence microscopy, you have the polymer fraction here in color-coded in gray. We see a 2 to 2.5-fold increase in amount of polymer that accumulates within the tumors. Same thing with two-photon microscopy, where we actually look at 500 micrometer Z-stacks of images, where you see the blood vessel network, and then the individual distribution of polymers extravasating out of the blood vessels into the tumor tissue. And also here we have a 2 to 4-fold, depending on dosing, increase in accumulation of the materials within tumors. And then we're currently actually looking at the penetration and the intratumoral distribution upon priming. So we draw concentric rings around the blood vessels, so the lectin-stained red structures, we draw rings around that, and we see what fraction of the polymers is in what ring, and there we see actually that also the distribution is improved. So it's not only within the first, let's say 10 micrometers of distance beyond the vessel, where most of the materials distribute, but actually really manage to find their way deeper into the tumor to reach more cancer cells. So that brings me to the summary. What I was trying to say is that tumor blood vessel networks and drug targeting to tumors are highly variable, and this is something that we need to consider if we want to make the translation of drugs and drug delivery systems more efficient. That CCR2 monocytes macrophages contribute to pathological angiogenesis. If we block the interaction between CCL2 and CCR2, we can normalize the tumor vasculature. This helps to improve the delivery of small and large drugs and drug delivery systems. And I think this also has, these strategies as such hold quite a lot of potential for immunotherapies. That's also one of the directions that the companies are now exploring, that you actually use such priming treatments to also modulate the balance between different types of macrophages, myeloid-derived suppressor cells within tumors prior to treatment with anti-PD-1 or anti-PD-L1 antibodies. So with that, I'd like to thank the people in the group, the funding agencies. A lot of this work was done by Diana Möckel, a technician in our department, together with Frank Takke, a gastroenterologist at the University Hospital in Aachen. I'd like to thank the organizers for giving me this slot to replace Daryl Irvine, and I'd be happy to take any questions.
Questions?
Hi, very interesting talk. It might be complete naive from my side, but isn't there a risk that normalization of this tumor vasculature would also enhance further dissemination of metastatic disease?
It's a question that comes every now and then. People are also afraid that if you normalize the vasculature, you would close the gaps that nanoparticles need to extravasate. I think in the end, it's all a balance. And similar priming strategies where you, for instance, use ultrasound to prime a tumor or so, they might all lead to shedding of more cancer cells into the bloodstream. I think in certain settings, if you consider patients with end-stage cancer or with metastatic disease, that's not a big problem. And even in your body, there are circulating tumor cells, quite a number. Right? What Jane did show, though, is that if you do normalization well, you lower the number of intravasating tumor cells from a tumor, simply by closing the gaps, very simply stated. I do think, though, that it's really difficult to accurately hit this exact normalization window, because it's dose and time dependent, and taking all the heterogeneity in patient features and vascular features into account will be very difficult to exactly hit this nice window.
There was one in the back. Take this first.
Well, this was a nice replacement from from the announced presentation. I have a question about the direct effect on the macrophages, because you showed how the treatment could do something with the blood vessels and the normalization. But do you also have measured if some of the effect can be due to that you have less macrophages, or the macrophages is phagocytosing the nanoparticles to a less extent, so it's more a direct effect and not just an indirect?
So the strategy works by taking away a soluble ligand. Right? So we have an RNA aptamer that depletes CCL2 from the bloodstream, so you will not have the gradient for those CCR2 macrophages to actually infiltrate that inflamed or tumorous sites. I do not think that would affect the phagocytosis of monocytes or macrophages within the tumor for nanoparticles. We haven't checked that, but it's just my gut feeling, because it's a different part of the process that we target.
Then we go one. Or, yeah, yep.
Have you tried to combine it with anti-VEGF drugs?
I think that would be an alternative strategy to do that, and that is in a way what people are doing in the clinic as well, right? They use anti-VEGF drugs. So the formulation I was talking about is entering clinical phase 1 trials now. We haven't done the combination with anti-VEGF, but I wonder if that would lead to better or more normalization. There are two different strategies to achieve normalization, so it may make sense, right? It's an option.
Yeah.
Stefan Krabbe.
I'd like to come back to the macrophages. Now, there's a tumor with macrophages in them, and they reshape the microvessels. Yeah. And then you come in with the CCL2 aptamers. What happens to the macrophages that are already there? So why are you actually improving the situation by blocking chemokine receptors when you have an already established immune micromilieu?
Because what we know from these settings in liver fibrosis is that those inflammatory macrophages that infiltrate the tumor, they contribute significantly to this pathological angiogenesis. So you're right in the sense that we do not do anything to the macrophages that are already in the tumor. I do not think that there is anything happening there. But we just try to keep away those macrophages that in the end disturb the vascular network for delivery.
So that would mean that there's a very active turnover of these macrophages in the tumor micromilieu.
I wouldn't know. I think that there will be macrophages dying, especially also if you do nano drug treatments, because they in the end very efficiently target tumor-associated macrophages. Because of that, you will have continuous inflammation ongoing, which leads to the shedding of multiple types of chemo and cytokines. And it's only this one subset that we actually looked at because we know it has this relation to the microenvironment and to the vasculature to see what the impact is on drug delivery. Right? And there we do see an increase of a factor 2 to 3, which is nice but not fantastic. In the end, it all, I think, comes down to showing that if we do this in a setup and combine it with an immunoblocking antibody, whether we get significant improvements. And that's in a way what the company is pursuing, to really break immunoprotection at the microenvironment, partially also via unknown mechanisms, right? Because nobody really knows what the exact function of CCR2 macrophages is. They have many types of functions. They're also not classical M2s, for sure not, but they're also not M1s. It's very dynamic. So it's something that is really being explored at the moment.
Are there other questions? Oh. Ladies first, I would say.
Nice. My question is somehow related to normalization windows. I wonder, I don't know, did you achieve this result with just single injection of formulation?
No, I don't think with any single injection you would be able to really properly get normalization of the vasculature unless you inject a long-acting formulation. So we did subcutaneous administration 3 times a week for 3 weeks. So it's 9 doses in total.
9 doses?
Yeah.
Okay.
So do you know why you get increased penetration in the tumor tissue also when you normalize the blood vessels?
It's something we've been looking at with different ways of quantification, and what I can say for now is that we do not really see enhanced penetration. So if you really look relatively how much is in the different compartments, we do see that this factor 2 to 4, depending on tumor and setting, that we see an enhanced accumulation in the overall tumor. It just spreads over the tumor. So it's not, like if you would do anti-collagenase treatments, for instance, you really see that a relatively much higher amount is able to enter deeper compartments. Here we, in a way, so well, slides off, it also doesn't matter. It's in a way a similar distribution of a factor 2 to 3 in all different compartments. So it's not specific penetration enhancement.
Okay, thanks.
Is there any other question?
Thank you very much for the interesting talk. I have a question about the timing of the treatment. At which stage of tumor development do you recommend this normalization effect? And if you do it early on in the tumor development, do you think this could be a way to minimize metastasis?
I think it's a good question. The pragmatic answer is mostly patients do not come at an early stage, right? So in a way, you're already forced to do this at later stages. I also do not think that people will intentionally do treatments only to normalize, because if you work with anti-VEGFs, for instance, that would mean underdosing. Right? So you would have to give VEGF blocking drugs at half the dose or so of what is clinically prescribed. And I don't think any oncologist would intentionally do that just to normalize. I do think that because of the huge variability that there is in vascular and microenvironmental features of tumors, in some of the tumors you might have complete pruning of blood vessels, in other tumors you might not do anything, and there might be a fraction of tumors that, independent of the stage, early or late stage where you treat, you will see vascular modulation. Right? Whether normalization is the right word, again, I don't know. It's more modulation of effects that we can use for better combination therapy. And that's probably also one of the reasons why these anti-VEGF drugs in the end did make it into clinical use, because they combine well with other drugs. And part of that is very likely due not to their classical anti-angiogenic mechanism, but to enhancing the delivery, accumulation, penetration, distribution of drugs when they're given in a combined setting.
There's a question in the back, maybe the last question.
Yeah, I think it's the last question, thanks. So have you studied just monocytes, or have you run any studies on myeloid-derived suppressor cells? And also, I think based on my studies, I see most of the researchers trying to suppress angiogenesis by using M1 macrophages, something like this. If you want to combine this study with such a like M1 related like nanoparticles, how do you want to do that?
I think in the end, what the ideal situation would be is that we do not induce anti-angiogenesis, because then if it's classical anti-angiogenesis, you would shut down perfusion and blood vessel access to the tumor. So nothing that would be combined with those drugs, also not immunotherapy, would be able to work. So you need to be in a balanced intermediate situation, I think. What would of course be brilliant if we consider immunotherapy combinations, where I think this will be going, is if also within the tumor microenvironment, we would see a tipping from, let's say, more M2-like dominated microenvironment towards more M1-like microenvironment, which would be better if you would combine it with anti-PD-1 or L1 or CTLA-4 antibodies. It's not something we have explored though, and something else we're exploring, but not with this formulation, is how can we target myeloid-derived suppressor cells, because they also play an extremely important role within the microenvironment, at least in certain tumor types. So I think this is something that in the next 5 years, both from the biology end, but also from the pharmacology and from the nano end, is something that we will all be working on. And those are, I think, things that within the SFB we will definitely start to look at together to try to get more knowledge on how to make that work better in the future.
Thank you very much. So let's thank Twan again.